chairman of oculoplasty at Gangaram, chairman of ophthalmology rather, and Shalu, who is a dear friend, again a senior consultant at Gangaram in oculoplasty, and we have two young consultants now, Dr. Shalin Shah and Dr. Tanvi, who will be joining us. They have both been trained under me at Maulana Azad Medical College, and of course I am Dr. Ruchi Goel. So I would like to invite Dr. Grover sir, Shalu, Shalin, and Tanvi, please come and join me here on the dais. Ajay sir. Aja Shalu. So the first talk. Okay, let's all settle down first, and I think all of us can come in the front so that we can interact. It should be a one-to-one interaction. That is what it is all about. So we are just skipping the anatomy part because as it is, I think we are 15 minutes delayed. So I will start with the involutional, entropian and ectropian. After that, we'll have the upper lid retraction as per the program. To begin with, I think first try and understand why does a involutional entropian or ectropian occur. So our lower lid, basically it is suspended by two horizontal forces and one vertical force. And when we talk of horizontal forces, it is the medial palpebral ligament, and on the other side there is the lateral palpebral ligament. And inferiorly, if you see, there's a vertical component, that is the tarsus, the lower border. We have the inferior lid retractors, and also it is basically the tarsal thickening which is important, which is serving as a skeleton for the lower lid. So as the age advances, what happens is there is a basically thinning of the tarsus, and the preorbicularis and the preseptal orbicularis, the preseptal and the pretarsal orbicularis, they tend to move over each other. So when will it happen? Whenever your vertical forces are at fault. So whenever you decide what surgery has to be done, pre-operative assessment of the structure at fault is most important. Now look at these pictures. If you look at the upper lid, she has an involutional component. What is happening? Dur karu? Pass karu? Achha. But you can see the lower lid is inturned, whereas the same thing is happening in the picture below, but the lower lid is outturned. So what we have to see is whether there is a generalized lid laxity, or it is combined with a medial canthal laxity and a lateral canthal laxity, or if there is an inferior lid retractor weakness. So how do we check it? You just pinch the lower lid, and if you are able to pinch it away about 6 to 8 millimeter, then that means your distraction test is positive. If you are able to, if you are able to pull this lateral canthus about 2 millimeter away, the punctum is pushed 2 millimeter away, that means there is a medial canthal laxity. In these patients, if you try and only address the generalized lid laxity, you may not have a very good post-operative result. So other thing that you have to see is whether there is a inferior lid retractor dehiscence. So what do? You tell the patient to look down. Normally what happens is about 1 to 2 millimeter, the lower lid moves down when you look down. But if that is not happening, that means there is an inferior lid retractor laxity. Lots of times, as a rule, I have seen lot of our residents, they just jump on to doing a Jones procedure, that is a inferior lid retractor plication in all entropian, involutional entropian cases, and end up with failures. So if you have a combined generalized lid laxity or medial canthal that is not addressed, simply doing a Jones procedure is not going to help. Now how do you grade it? Suppose you have an ectropian, you have to grade it so that you know what procedure you have to choose and how much you expect that the correction will be there. So when the puncta is not opposed to the globe on looking up, it's mild. When it is not opposed to the globe, even in the primary gaze, it's moderate. And if it is not opposed, even and the fornix is also exposed, then it is a severe ectropian. Now I'll just show you a couple of videos. So you can see this patient. This patient had a generalized involutional in generalized lid laxity with involutional entropion. So the procedure of choice in this case was a modified Wheeler. So what you do is you mark 4 millimeter from the lid margin, and then you expose the orbicularis muscle in front of the tarsus. So this is the orbicularis belt which is in exposed, and you do a triangle. The tarsus is cut with a base down triangle. Remember, when you're correcting an entropion, the triangle has to be base down because you want to shorten the lower part of the tarsus, not the upper part. Whereas when you're correcting the ectropion, it is reverse. So you take out this triangle, suture the ends of the tarsus back, and then you do a double breasting of the orbicularis. And on table itself, you get a very good correction. This is the simplest procedure and can be easily done with very reproducible results. Immediately post-operatively, there may not be a very good contour on the first day, but eventually it takes its place and it gives a very good result. Now remember that tarsal strip procedure is a procedure which is used extensively both for entropion and ectropion. Now how does it differ whether you're using it for entropion or ectropion? One part. The other thing is, do we do tarsal strip procedure in isolation, or do we combine it with other procedure? So if your medial canthal tendon is not very lax, then you can simply do a lateral tarsal strip procedure both for ectropion and entropion. The difference is here, if you see these sutures, in entropion, these sutures, this is the cut end of the tarsus, these sutures are passing just from the upper and the lower border of the tarsus. Whereas when you are correcting the entropion, what you are doing, एक मिनट आप वो कर दीजिए, टाइम वो कर दीजिए. So when you are correcting the entropion, what you want to do is that you should have basically the lower part also to be sutured. एक मिनट मेरा कर्सर छोड़ दीजिए. हाँ. So you can have this suture which is passing from the lower border also. So this gives a correction for the entropion. So just to see the video now. So this patient has an ectropion. So what we do is we do a lateral cantholysis first, and then we expose the lateral border of the tarsus. And once a strip of this tarsus is exposed, then you just pull it up laterally. And remember, this tarsus has to be inserted to the lateral tubercle. So this lateral tubercle is about 4 millimeter interior to the inner border of the orbital margin laterally. So you should not just insert it right at the margin. And this is the excess of the skin is then excised. So again, if you have to correct the entropion, you remember the suture placement which I have shown in the figure below. Now what is the advantage over the full thickness lid resection is that if you do a full thickness lid resection, there were problems related to notching, and also there was loss of granular secretions, whereas in lateral tarsal strip procedure, the problems that have been documented is that since the tarsus is being inserted directly to the orbital margin, there have been formation of granulomas related to the meibomian glands. Now another procedure, that is the subdurgent suture, that was described by Dr. Malik et al., and we later on studied it further using a 5-0 proline suture to suspend the, I'll just show you a video later, suspend the lower lid in involutional ectropion, and I'll show you the video together. And this can be combined with various procedures, that is the medial conjunctivoplasty, where you just have to correct the medial ectropion. So you can combine the two procedures. And this is a small click where both the scar below is not actually the cause of ectropion. This is a horizontal incision which is given at the lateral tarsus, lateral canthal, and from here you pass the needle, straight needle, which is this is the proline suture, which is first tied onto the lateral canthus, and then a straight needle is passed from the lateral canthus to the medial canthus. This proline suture is also anchored to the adjacent periosteum, otherwise it tends to slip away. And remember, it has to be buried very well, because all proline sutures, they have a memory and they tend to cause extrusion at a later date, so it has to be buried well. And this is a curvilinear, like a DCR incision that you place. You expose the medial canthal tendon, and then you This is combined with a medial conjunctivoplasty where a tarsoconjunctival strip is removed, and you can see this is a 4 by 8 millimeter rhomboid kind of incision which is made. And after exposing, the sutures are passed from both the lips and it is brought out to the skin and tied on to a bolster. So this is the medial conjunctivoplasty, and it immediately interns your punctum. Now this is the needle which I was saying, a straight needle is passed from the lateral end to the medial end. It is brought out and it is tied onto the medial canthal tendon here, and then it is buried in layers. So this is combination of the two techniques. So whenever you have such a problem, you may combine 2 or 3 procedures to give a perfect result. So this is then tied, and what is most important is that it has to be sutured in layers, otherwise there is a chance of suture exposure. Now we studied this is a polypropylene sling, that is the 50 proline with combined transconjunctival retractor plication and tarsal strip procedure, and we found equally good results with both the procedures. Only thing was there was some cases where the proline got exposed, and for that we had to intervene later. Now this is another technique which we have recently been started doing. This is a silicone sling which we use routinely for our ptosis surgery. I tried using it instead of the proline because proline was having exposure related problems, so we started using this, and this was passed from medial to the lateral canthal angle similar to what we were using the fibroproline. So this is the silicone sling. The only problem with silicone sling is that since it has a chance of extrusion, so you have to be very careful in burying it. And this needle which is there, it is not as pliable as I was using the other needle. So passing it becomes a little difficult, especially if a patient has a very long nose, prominent nose. But otherwise, in patients where it is done well, it is giving good results. And especially, I would not recommend it for mild ectropion, but for patients like paralytic ectropion, especially post-facial palsy, this is another procedure which can be tried other than, of course, doing tarsorrhaphies, which we usually do, lateral tarsorrhaphy and medial canthopexies that we do. So this gives a very good, adequately good correction post-operatively. Another thing that you have to be careful is not to pass it. It has to be in the correct plane. It has to be close to the lid margin in the pre-tarsal plane. So just to conclude, a preoperative assessment of the structure at fault is important, and the procedure has to be chosen accordingly. Mostly lateral tarsal strip procedure works in most of the cases, which may be combined with medial canthal plication or inferior lid retractor plication. Thank you so much. And of course, this is a book which will be released today. This is 20 years of hard work, and of course contribution from a lot of co-authors like Dr. Grover, Shalu, and my residents Shalin, Tonvi, and so many others who have helped me in bringing out of this book. Thank you so much. So next, Dr. Grover will be speaking on upper lid retraction.
Thank you, Dr. Ruchi, for making me a part of this nice session. So I'll be speaking on management of eyelid retraction. The surgical management of eyelid retraction is very commonly a part of thyroid eye disease, where you follow the sequence of taking care of first the orbital decompression to get the globe in right position, then taking care of the motility, and the eyelid surgery is the final consequence. So an example is this, where we take care of proptosis first before going on to eyelid retraction correction. What are the surgical objectives when you want to correct an eyelid retraction? You want to abolish the scleral show, which may be disfiguring like you see here, and production of a normal eyelid contour is important because many of these cases have a temporal flare. what is important is that the eyelid crease can often get recessed when you do this surgery. So you would try and maintain the eyelid crease as best as possible, and in unilateral or bilateral cases, getting a symmetry is also again a major issue, because eyelid retraction is probably less predictable than ptosis surgery and needs that much more precision if you can, but at least try your best with your experience to try and get the results as symmetrical as possible by on the table assessments. So essential principles are weakening of the levator complex, where you can excise the Miller's, which is lifting up the eyelid, and you may need to combine it with levator weakening or giving a incision through the eyelid or blepharotomy. The other principle is that you lengthen the levator itself. You don't just recess, because that often tends to reverse back. So you need to lengthen it by putting in a spacer as well, or you can just do myotomy at both the ends in order to get a recession or lengthening. So let's look at the approaches that are used. This is the conjunctival approach, where you are dissecting the Miller's muscle away and excising it, or the anterior approach, transcutaneous, which we are using in a blepharotomy or a spacer. So what procedure do you choose? Choice of surgical procedure for mild cases up to 2 millimeters is usually Müllerectomy, but sometimes for contour correction you may need a levator tenotomy as well. In moderate cases, you need to often combine Müllerectomy with levator recession or tenotomy, or a blepharotomy is then the procedure of choice in the severer grades of up to about 4 millimeters or more. And if it is more than 4 millimeters, then blepharotomy is possibly one choice, but in very severe cases, spacers possibly become integral to the procedure. A number of spacer materials have been used, but the ones that I have used commonly include hard palate and autologous sclera. So we'll see a video with a scleral thing, but let's go on to Müllerectomy. So first thing is to try and create a plane between the conjunctiva and Miller's and the tarsal Miller's and the levator. So this is the incision at the upper border of tarsus, and then you create a plane first between the Miller's and the levator by dissection, and an assistant holding the edge of conjunctiva or sutures, as you will see in the next video, may be a good option, and then you create that plane between the Miller's muscle and the conjunctiva and dissect it. You can do it in one go, or you can do it in two halves, as you are seeing here. Create that plane with your dissection, dissect away all the Miller's muscle for a height of up to generally about 8 millimeters. Severer cases may do a little more, and you excise it all the way up to the upper border of the conjunctiva. And then you may or may not combine it with levator tenotomy. You may use a 8-0 Weichel for closure, making sure you take small bites so that you don't cause an exposure, suture keratopathy. Here we are lifting off conjunctiva a little bit with forceps to create that plane of cleavage, using sutures for the retraction or holding of the conjunctiva, and then dissecting again between Miller's and the levator complex, as you see here. So this was a little severer, where we are planning a combined procedure.
Sir, please continue, sir.
Thank you.
ये हटा दीजिए, please.
So this is the dissection that continues between the plane between the Miller's and the conjunctiva. That dissection is completed, and the fibers of Miller's are excised. But then you need to correct in the severer cases, not just the temporal flare that many of these cases have, and you do an on-the-table assessment. Many of them may need a further weakening of the levator by dissecting those fibers And on the table, assessment tells you that you probably need to do more for the temporal flare, and we are doing that. Till you are satisfied with the correction and contour, a little overcorrection on the table with a little ptosis creation is essential. And then you can suture with either the technique of 80 Vicryl that you saw, or we sometimes use a 6-0 nylon suture starting from the skin end, coming out at the skin end with small bites. So examples are a moderate lid retraction where we have corrected, this is the moderate retraction that you see here. It's about 3 millimeters, 3.5 millimeters, and this is the post-op result after muellerectomy and levator tenotomy in up gaze, down gaze. So full thickness blepharotomy is the procedure for the more severe cases. Anywhere between 3 and 5, I would probably go ahead with full thickness blepharotomy. So we've given an incision in the skin crease line, dissected first the orbicularis, then go through the structures, dissect between the levator and the conjunctiva bullous complex, lifting up the entire lot of levator, possibly with Miller's, and then excise it from its attachment onto the tarsal surface. So dissecting this away, and then you need to assess what the correction that you wanted, whether it has been achieved or not. And once you decide that you need a greater correction, then you would probably go ahead with incision of the conjunctiva full thickness on either sides, leaving a central pillar of about 5 millimeters to maintain the shape and the contour. So this is, we've done a blepharotomy on one side, but this is a matter of titration. So this is what is very important, that you do not over or underdo it. So here we've done nearly a full thickness blepharotomy. We are assessing whether this will do till we get the right correction and the contour. So this was a patient with proptosis and lid retraction where we've done a blepharotomy. This is an early post-op picture with correction. So this was a patient who had a ptosis surgery done, was an acquired ptosis, and ended up with a gross overcorrection done by a non-regular oculoplastic surgeon. So this was ended up with a retraction which was almost 6 millimeters. And he was a very suicidal patient who forced us to do his surgery. So we went ahead and did a correction with a scleral graft. Unfortunately, I think we saved a life by getting his correction right. Remember this patient? Okay, so you have to space, you have to have the spacer, which is, this was a scleral graft, which is about 1.5 to 2 times larger than the correction that you require, and it has to be shaped well, it has to be attached to the tarsus, and it has to be attached superiorly to the recessed edges of the levator, and then again assessment, and then closure of the skin muscle. So this is an example of a transconjunctival orbital decompression for cosmetic indication, followed by a blepharotomy for correction of the eyelid retraction. We'll skip the lower eyelid retraction, hard palate graft, and stage procedures. As we said, you first do a decompression, followed by a hard palate graft for correction of these cases. Thank you very much. Thank you again.
Thank you, sir, for this wonderful presentation. Just, sir, to add, we do get patients who in active TED, they are advised eyelid retraction surgery, so that the message should be that no intervention during the active phase of TED. So that is one thing, sir.
So
do you
not
use,
just the systemic part of it needs to be well controlled,
yes,
but at the same time you have to make sure that stability has been achieved. So we don't normally would give about 6 months to ensure that everything on systemic and the ocular front is stable.
So do you use silicone bands ever for upper lid retraction? I've used, they have good results.
I used them for entropion correction long time ago for those when I was in GNEC. When that time the maximum cases we used to do was failed entropians where they had lost their tarsals. So as a tarsal support I had used them, but then I realized it is too thin a structure to have a silicon band there.
No, sir,
And
I'm
I
talking
had
about
to,
the
yeah,
upper lid.
maybe at that time हम अनाड़ी भी थे तब,
Upper lid के लिए, sir.
शुरू कर रहे थे oculoplastic career. So some of them got exposed also. So thereafter I have not used a material like silicon in upper lid. I would much rather use a hard palate graft or something.
Yeah, it's hard palate. Thank you so much, sir. So now we would invite Dr. Shalu. Dr. Shalu Bageja, as I said, is a consultant in oculoplasty at Gangaram Hospital, New Delhi, and she'll be speaking on dystrichiasis and trichiasis. Timer 10 minutes का लगाइए, आपके 5 minute का timer लगा हुआ है, please.
Good afternoon, everyone, and I'd like to thank Dr. Ruchi for including me in her course. So, I'll be basically discussing the dystrichiasis and trichiasis. Excuse me, this is not moving. So, dystrichiasis, we all know, is the aberrant growth of the lashes from or near the meibomian gland orifice, while trichiasis is the normal position of the lashes, but they are misdirected towards the ocular surface, and not moving, please. So dystrichiasis can be congenital or acquired. However, trichiasis is mostly acquired in nature, and congenital dystrichiasis is most frequently inherited as autosomal dominant condition, which is associated with systemic lymphedema due to abnormality of FOXC2 gene. However, the acquired dystrichiasis or trichiasis can occur due to any inflammatory condition following infection, autoimmune disorder, or inflammatory causes. So all these patients present to us mainly with the foreign body sensation, watering, photophobia, and if untreated can have ocular and visual problems. So coming to the management of this distress condition, symptomatic treatment is given initially lubrication in form of drops or gels, and in severe cases we may have to give bandage contact lens to prevent the keratopathy. The choice of the surgical procedure depends on the extent of the lid margin involved and is there any history of previous treatment. So if only few dystrichiatic lashes are present like this, in an isolated 1 or 2 lashes are present, we can opt for manual appellation with forceps. However, we know the lashes regrow in 4 to 6 weeks. So electrolysis was initially done where the electric current was passed. It causes the lateral heat and excessive scarring of the lids. So nowadays we opt for radiofrequency electrolysis. Laser ablation, diode or argon laser has also been described along with the eyelash definition, which I don't have personal experience. So the radiofrequency ablation gives a good result. In this, after giving the local anesthesia, the needle is passed deep into the lash roots. About 2 to 2.5 millimeter depth should be attained so that we reach the bulb root, and 1 to 2 seconds of 2 millijoule of power, and we see that the bubble appears, and we can remove the lash without any force. And if about segment or half of the lid is involved like this, then we have the treatment modalities of choice like excision of lash root via the trapdoor, or wedge excision in cases of we can do a pentagon excision and reconstruct the lid as in a normal marginal repair, or we can go for cryotherapy. So lid splitting with cryotherapy has the advantage that it does not cause the complication like depigmentation. So we opt for the lid splitting of the 2 lamella and give the cryotherapy. It's a double free thaw cycle is given in the posterior lid margin. And with the help of because of the lower temperature, the bulb of the lash is destroyed and the recurrence rate are less. So the as high as 90 to 91% of success rate has been written, and some surgeon prefer to combine it with the anterior lamellar recession also. As I already described, that the cryotherapy can cause the complication like lid margin distortion. So the lid splitting needs to be the integral part of the cryotherapy, so we avoid the depigmentation or the distortion of the eyelid. In case we have recurrent previous failed procedures, or there is the involvement of almost whole of the eyelids, so the basic treatment modality should be the resection of the posterior lid margin along and replacing it with the buccal mucosa or the tarsoconjunctival graft. Though I have not used the tarsoconjunctival graft, I have used only the buccal mucosa, but the literature says if you have excised much of the tarsus so that you are not sure of the integrity of the eyelid, so you can replace it with tarsoconjunctival graft also. And in case there is a eyelid malposition as in trichiasis, you can go for anterior rotation like tarsofracture or blepharotomy. So in this we do the eyelid splitting and the buccal mucosa is used, and we need a small strip, so we don't need to harvest much of the buccal mucosa. We take as we take from the buccal mucosa, we divide it into two parts and then suture it to the anterior and the posterior lid margin. And we can use the bolster to for the proper hemostasis will be achieved in the graft. This is a small video where we showing the lid splitting. It should be anterior to the distichiatic lashes, so that we take the integral part of the surgery is that all the distichiatic lashes should be removed along with the when we are excising the posterior lamella, the tarsus. So if we leave the lash root, then they may recur. So it's important that we should remove all the tarsus sufficient, so that all the lash roots are removed, all the distichiatic lashes are removed. So once we measure it, we take a slightly larger graft, about 10 to 15% larger graft, and then the lip mucosa graft. This can be undermined and sutured as the size of the graft is not much. And after thinning the graft, we cut it into two halves. We can use the glue also, so that the sutures may rub the posterior corneal surface, so we can use the glue and can have some atovical sutures, so that we don't lose the graft. Just for additional support, we can put the atovical suture also intermittently. This is a small video showing the patient with secretial entropium with trichiasis, where we have done the tarsal fracture so that the trichiatic lashes are moved forward. So in this, with the radiofrequency needle, the full thickness tarsus is cut, and 3 double arm sutures are used for the rotation of the lid. So once we have cut the whole tarsus, we do the slight undermining so that we can enable the rotation of the lid properly. And we are using a 5/0 silk suture, which is passed from the distal end and then coming out below the tarsus near the lash root. So once we tighten it, it causes the rotation of the eyelid margin. The pass to the sutures over the bolster, and is kept for 2 weeks. And then after 2 weeks, we can remove the bolster. So the 3 sutures are passed like this, double arm sutures are passed, so that we have a adequate rotation of whole of the eyelid. So this is just the pre and the post-op picture of the patient. So the electrolysis is a non-surgical management which we can use for the small, the isolated lashes, and cryotherapy can also be used as the most frequently used modalities. But however, they have a recurrence rate of electrolysis is believed to have a recurrence rate of, with radiofrequency it has a 60 to 70%, and cryotherapy as about 80% of recurrences. But if the recurrent lashes are appearing and if the whole of the lid is involved, then it's better to do the lid splitting along with the excision of the posterior marginal strip and replacing it with the mucous membrane graft, which give us the good results and long-standing results. Thank you.
So thank you, Dr. Shalu, for the beautiful videos that you have shown. And I would agree that actually lid splitting and putting a mucous membrane graft is much, because cryo, I don't find it a very useful procedure. I don't know what sir has more experience.
For localized ones, it works.
It works. But recurrences do occur.
If there are occasional hair, then you do a art. But if you reduce them by 80%,
So
you don't always have to do a graft in smaller or localized.
yeah, when it's a entire like distic cases, congenital distic cases especially, then it better to. So now we have next in. So Dr. Tanvi would be speaking on upper lid entropion.
Good evening, everyone. My name is Dr. Tanvi, and I'll give you a brief overview about the upper lid entropion types and the surgeries for the same. It's not going ahead. Okay. So we know the types of entropion. They're mechanical, involutional, spastic, and most commonly cicatricial. So usually the upper lid is most commonly affected by a group of conditions which result in fibrosis, scarring, and shortening of the posterior lamella. So all of these are grouped under the term of cicatricial entropion. What are the most common conditions? Cicatricial pemphigoid, Stevens-Johnson syndrome, trachoma, burns. All of these basically result in conjunctival scarring and posterior lamellar shortening. When we examine the patient, there are also associated features of scarring like symblepharon, keratinization, and phonacial shortening. So when we decide to go ahead with treatment for cicatricial entropion of the upper lid, what are the things we look for? One is the grade of entropion. Is it mild, not requiring surgery or just some local treatment? Or is it severe enough requiring surgical intervention? Second, thickness of the tarsus. Is it thick enough to require a part of the tarsus to be removed, or is it thin enough to resort to some other procedures? Third, the presence of lid retraction. Because it's a cicatrizing process, it results in shortening of the posterior lamella, and sometimes the retraction can be so severe that on closure of the lids, both the lids do not meet. So depending upon the grade of retraction, we can again choose a different type of surgical procedure. And last is the keratinization of the lid margin. If there is metaplasia at the lid margin and the lid margin is keratinized, we have to resort to surgical procedures which would take the keratinized lid margin away from the cornea. So a brief overview depending upon the severity of the entropion. One is mild disease. Sometimes the disease can be so mild that it can be just a few aberrant lashes which rub over the corneal surface. It may not be a completely full-blown entropion which causes inturning of the margin. In such a case, as Dr. Shalu ma'am already described, we can just split the lid margin with cryotherapy to the lash root. Sometimes we can just do a lash follicle excision after gray line split. Another procedure that can be done is anterior lamellar repositioning. This is the picture which shows the cryotherapy. Now in anterior lamellar repositioning, what is done is a lid crease incision is given and we expose the anterior surface of the tarsus right up till the lash root. And then a suture is passed which starts at the skin surface and goes up to the tarsus. This basically gives an upward pull to the anterior lamella and takes the lashes away from the corneal surface. So in this picture, as we can see, there is a lid crease incision given. Dissection is done to expose the anterior surface of the tarsus. And here we can see the passage of the suture. The suture passes in the anterior lamella just above the lash line. It comes out and hitches to the tarsus at a higher level. And this is the surgical result at the end, causing anterior lamellar, an upward pull towards the anterior lamella. Now, what about a moderate disease? If the disease is slightly moderate, these procedures are not going to be effective. So in such a case, we look at the thickness of the tarsus. Is it mild, is it normal thickness, or is it thickened? So if it's thickened, we have to take a wedge out of the tarsus. Whereas if it's a normal thickness of the tarsus, we have to resort to other procedures. Now this is a video which shows the tarsal fracture repair. So the lid is everted. An incision is given over the tarsus 4 mm from the lid margin. A full thickness incision is given through the thickened tarsus, and this is the orbicularis underneath it. As already seen previously by Shalu ma'am, the sutures are passed from the proximal end of the cut end of the tarsus to the distal end, and this comes out at the anterior lash line. These sutures are passed at 3 points: central, medially, and laterally. And the sutures are tied over bolsters on the skin surface. So this is the result at the end of the case. This is another patient who underwent tarsal fracture. As we can see, the tarsus is extremely thickened. This is a patient of trachoma. As we can see that the suture has been passed from the proximal cut end to the distal, and then towards the anterior. It's important that when we take it out of the skin surface, it has to be anterior to the lash line. What about lamellar division and mucous membrane grafting? This is another procedure that can be done where the tarsal thickness is not too much. So in such a case, a gray line split is done, and the anterior and posterior lamella are split. The posterior lamella is then advanced about 4 mm below the anterior lamella. So even if the lash line, even if there is an entropion, this posterior lamella now serves as a barrier between the lashes and the cornea. So this is another pictorial representation. A gray line split is done, and the anterior and posterior lamella are separated. As we can see, the sutures are passed from the anterior lamella, and they're then sutured to the posterior surface, or to the anterior surface of the tarsus. And this is the end result, where the posterior lamella has been advanced as compared to the anterior one. This is another patient who underwent posterior lamellar advancement, and this is what the patient looks like. This is the advanced posterior lamella, and this is the anterior one. So now we discussed what if a patient has a thickened tarsus, like in cases of trachoma. So in such a case, it's important that we take a wedge out of that tarsus and evert the lid. So this is a video which shows the tarsal wedge dissection. A gray line split is done first, followed by a lid crease incision. Following this incision, the orbicularis is separated to expose the anterior surface of the tarsus. Now an incision is being made over the tarsal surface in the form of a wedge. It's important that when we create this wedge, it should be in such a shape that it is with the edges facing downwards. It should be in the form of a spindle. And now the sutures are passed to evert the lid. So it's passed from the skin side very close to the lash line, from the distal cut end of the tarsus to the proximal cut end of the tarsus, and back out at the lash line. This is in the form of a horizontal mattress suture. 3 of these sutures are passed centrally, medially, and laterally. This is what the end result is. Now, what if it's a very, very severe cicatrization? In such a case, the lids do not close when the patient attempts to close the eye. So in such a case, we either free the conjunctiva from the Mueller's muscle in mild cases of retraction, but if it is severe, we need to lengthen the posterior lamella with either a graft or with, in very, very severe cases, tarsal excision. So what do we do in a posterior lamellar graft? In simple terms, we just give a full thickness incision at the tarsus. We create a space between the distal and proximal tarsal segment, and then we place a posterior lamellar graft. This graft usually tends to be either nasal mucoperichondrium or it could be hard palate mucosa. This is a patient who underwent the same procedure, and this is the proximal and the distal end of the tarsus, and this is a buccal mucosal graft that has been placed in between. Now sometimes the tarsus is so severely cicatrized and scarred that it is not possible to do any of these previous procedures. So in such a case, we just excise the tarsus. So gray line split is done, and this severely scarred and fibrotic tarsus is excised. The retractors are recessed, and this is sutured to the anterior lamella using sutures. And last but not the least, the rotation of the terminal tarsus. Now this happens when we discussed the last point, keratinization of the lid margin. Now what if the lid margin is keratinized? We need to take it away from the cornea. So what do we do in such a case? We basically give a full thickness incision at the tarsus, and the distal segment is turned 180 degrees. The posterior lamella is then advanced inferiorly, and this forms the new lid margin. And then they are sutured together. So this is not very commonly done, but it's one of the procedures that can be resorted to. So I'd like to conclude, most commonly upper lid is affected by cicatrizing causes like cicatricial, so they are grouped under cicatricial entropion. So our primary modality of management in these cases is to control the systemic inflammatory conditions and then go ahead with a surgical intervention. Since most of these involve thickening of the tarsus, our main principle of surgery involves sectioning the tarsus horizontally so that the lower segment and the lashes turn up. Thank you.
So thank you, Dr. Tanvi, for extensively covering the cicatricial entropion of the upper lid. And now we have Dr. Shalin Shah, who will be speaking on brow ptosis and blepharoplasty.
So, good evening, everyone. I think we have had a lot of theoretical knowledge. I would like to take you through some of the cases that we commonly see in our OPD and whether to intervene or not, and how to intervene and correct these cases. So, what periocular aesthetic patients come to us? They come with problems of the forehead and brow, that is one. They come with upper lid issues and lower lid issues. So in the forehead and brow, most commonly we see forehead descent. These are usually 50 plus patients. They have forehead descent and then associated they have brow ptosis. We often have younger patients who come with brow ptosis, temporal brow ptosis and resorption of the temporal fat, which is known as temporal hollowing. And there are some patients in the 45 to 50-year-old age group who come with a superior sulcus deformity and a resorption of the supraorbital rim and resorption of the brow fat, which is the regression of the supraorbital ridge. Then there are some upper lid issues like aponeurotic ptosis, which is often associated with cases of dermatochalasis or blepharochalasis. There could be orbital fat or lacrimal gland prolapse, which could lead to unsatisfactory appearance. And there could always be some superior sulcus deformity following fat absorption. And there are some lower lid issues like retraction or lower lid ptosis, that is inverse ptosis. Then what we commonly see in 25 to 35-year-old patients are lower lid wrinkles and crow's feet, which they are unhappy with. There could also be associated fluid bags, orbital fat prolapse, and a very common tear trough deformity, which we usually see in the OPD. So each of these pathologies, they need to be addressed specifically, and some of them they can coexist, and we need to offer a comprehensive approach for a full facial rejuvenation in these cases and not just correct one of them. So what do? We need to offer a cafeteria approach to these patients. We need to enlist what all deformities or what all issues are there to be addressed, what all can be done, surgical, medical procedures, and then allow the patient to choose what they want to be done on themselves. Because at the end of the day, we have a fraction of patients who are not going to be happy despite all our efforts. And then there are the body dysmorphia kind of patients who, despite best results, would not be satisfied. So we leave the decision to the patient in these cases. So this is one of our cases. This was a 45-year-old lady who presented with excess skin on both of her lids, and it was bothering her. And so we can see that she has bilateral upper lid blepharochalasis, and she also has a tear trough deformity, but she was not bothered by the tear trough deformity or the lower lid wrinkles. She was just bothered about the upper lid, and hence we planned her for bilateral upper lid blepharoplasty. And okay, so these were her results. Actually, this is a follow-up at 1 year. She had sent this photo to us saying that she's very happy and she looks 25 from her age of 45. So, and she was not bothered by her tear trough deformity or anything. Okay, so this was our second case. This was a 20-year-old girl, and the father had brought her with excessive skin over the right eye. And they had noticed this. And she was to be undergoing, her marriage was decided, and they wanted a cosmetic correction for this purpose. She also had associated lower lid retraction, but again the patient was not bothered, and the patient did not want a surgery for that. So she underwent a simple right upper lid blepharoplasty, and she had good correction post that, as can be seen in the photograph. So this was another patient. She was around 25-year-old patient. She had history of recurrent VKC in both eyes. And since last 2 years, she had noticed a slight swelling on the left lower lid. And on eversion, no cyst or anything was found, only orbital fat prolapse was seen. She also had bilateral tear trough deformity with slight hyperpigmentation, but she did not want any correction for that. She just wanted the lump from the left lower lid to be gone. So we planned her for lower lid fat debulking, and this was her follow-up picture, and she was extremely happy with the result despite the persistent periocular pigmentation. Now we come to slightly more complicated cases we have faced. So this gentleman was 45-year-old, and his employer had said that you look tired every day, and that's why he had come to us. And we can see he has upper lid fat prolapse, lower lid fat prolapse, and dermatochalasis, and a significant tear trough deformity. And he was ready for whatever procedure was needed to help him look rejuvenated when he went to his office and faced his manager. So we went for bilateral upper lid blepharoplasty with fat excision and lower lid blepharoplasty with fat repositioning in the preperiosteal plane. And I operated this recently, and I don't really have a follow-up of this patient. Now this was a 26-year-old patient who was extremely bothered by the facial wrinkles and the crow's feet, and he was ready for a surgical intervention, but we offered him microbotox, 2 units into the pretarsal orbicularis and 4 units into the crow's feet. And this is the appearance after microbotox, where his creases are significantly reduced, and so a surgical blepharoplasty or an intervention, transconjunctival or skin-based surgery is not always the answer for these patients. This was another patient who was 40-year-old patient, male patient, who presented with a tear trough deformity which was bothering him, and there was no associated hyperpigmentation. So we advised him fillers, hyaluronic acid fillers in the left lower lid, and this was the appearance after 2 weeks, where you can see that just the filling of the tear trough deformity led to an acceptable outcome for the patient. So again, non-surgical approach. And so now this patient was an 18-year-old female who presented to us with excess skin on both upper eyelids, and we noticed that she had a slight aponeurotic ptosis in the right upper lid, as well as right lower lid retraction and wrinkles. So we planned her for a blepharoplasty with a right upper lid levator resection and bilateral lower lid microbotox. And she had a very, it's not moving, okay. She had a good correction at 6 months, and she's happy. Now I come to, so this was a patient of facial palsy who left-sided lower motor neuron facial palsy, who presented with brow ptosis, and she was actually bothered by the dermatochalasis, which was interfering with her field of vision, and we planned her for a brow pexy with blepharoplasty. So in such cases, just a blepharoplasty may not be the answer. And this patient was a 45-year-old female who was bothered by the superior sulcus deformity. On palpation, we noted that there was actually a regression of the supraorbital rim, and we advised her bilateral subbrow hyaluronic acid fillers, and in the suborbicularis plane, we injected the fillers, and this was the appearance at 3 weeks. Okay, yeah, just give me 2 minutes.
Charlene, you have to wind up. It's 5:10.
Okay.
We have to.
Okay, so so surgery or an intervention is not always the answer. So I present 2 more cases in very brief. So this was a 45-year-old lady who was referred to us for ptosis correction and blepharoplasty of the right upper lid. But on history, we found that she had recurrent episodes, and on imaging, we found that she had bilateral lacrimal gland enlargement, and she turned out to be a case of non-specific orbital inflammatory disease. And we planned her on systemic steroids to control the inflammation. So this is one of the cases where despite a bulky upper lid and ptosis, we should not operate. And this was one another patient who presented with bilateral orbital puffiness, who was referred to us for blepharoplasty. On extensive history, we found that he had kidney failure, which was missed by the previously examining ophthalmologist, and he was counseled and he was ready for a blepharoplasty, but this is again a case where he needs a systemic correction, he needs dialysis and control of his kidney functions before going for a surgical intervention. So we should not operate every patient with dermatochalasis or fat prolapse that we see in our OPDs. Thank you.
Thank you so much, Shali. We have, I think, less time, so I'll just cut short the congenital ptosis and then. अरे पीपीटी कौन सी है? अच्छा ठीक है, okay. So what I'll do is I'll just skip all the slides. I'll just show you a couple of videos only. And congenital ptosis, I think it's the commonest thing we all encounter. And I assume that the workup is known by all of us. Mild ptosis, 2 millimeter difference in the MRD1 between two eyes. 3 millimeter is moderate and severe is more than 3 millimeter. The most important part is one should check whether the patient has a good Bell's, the amount of levator excursion one has to check, and depending on that we have to decide what surgery has to be done. For mild ptosis, Fastenella survey, small resections, MMCRs, these are the procedures which are being used. For moderate ptosis, then depending on the LPS action, we can go ahead and do an LPS resection. And for severe ptosis, we have a sling procedure, that is the silicone sling, it is standard, and nowadays we have started doing levator resection with frontalis advancement flap. So I'll start with the levator advancement with frontalis advancement, which is something which is recently become very popular. I'll show the landmarks in this video only. I'll take just about 6 minutes and then we can come back. So the first thing that you need to do for any levator resection or any of these procedures is you should do a central marking so that you know where your highest point has to be placed. And then the lid crease incision, you can use the other lid as a guide, or if it is usually in females, it's about 8 millimeter if you don't have a very good lid crease. So this is the orbicularis and the LPS being separated. So remember the upper lid, it has two lamella, and from top to bottom, if you go from superficial to deep, you go from the skin and then the orbicularis. And now this is basically, in this patient, the frontalis has been advanced. So this is the superior orbital margin, and here the frontalis muscle is being disinserted, and this disinserted muscle will be basically pulled down and it will be sutured onto the tarsus. So this is a procedure which is now quite often used in severe ptosis by us, and also in patients where the silicone sling has failed or it is not being, it is having a lot of complications like exposure and the patient is not able to tolerate the sling. So it's a very useful procedure in these patients. Mind you, the problems with it is especially the lash ptosis. So this is, you can see the frontalis muscle is being separated, and remember it is quite closely adhered to the subbrow fat, so that it has to be separated so that once you pull it down, the brow also does not get pulled down with it. So there has to be a good dissection in front and behind the there's a frontalis muscle, and after that the levator is disinserted. Remember, the levator is inserting about 3 to 4 millimeter on the anterior surface of the tarsus. So these are the vertical fibers of the levator which are being dissected, and this LPS dissection is carried out till the Wittnall's ligament. So after the two horns are cut, the medial and the lateral, and you dissect it right till the Wittnall's ligament. So these are the posterior fibers of LPS which are separated, and once the LPS is mobilized, you can see this is the orbicularis And after that, the orbital septum, you can see it is open, and the orbital fat is right in front of the LPS aponeurosis. So you can see this white colored structure, this is the Wittnau's ligament. So this is a landmark till where we have to dissect. And after that, the insertion is as we do it in any LPS resection. It is passed from the tarsus, and the bite is taken from the LPS just in front of the Wittnau's ligament, and then onto the frontalis. Now, how much frontalis to be sutured? This has to be titrated on table. Actually, there are no set algorithms for this. And once this is done, what is most important is that the excess of LPS and frontalis, they are excised, and good lid crease for multiple lid crease forming sutures have to be placed. Otherwise, you tend to have a large ptosis. So this is the excess skin that is excised, and then you give lid crease forming sutures. So this is how you do a levator advancement. एक मिनट लगाना जरा भैया, एक मिनट जरा दे दो वापस. Okay, so now I will go to a patient with MMCR. How do you do if you have a small amount of ptosis? Usually classically we do this procedure for aponeurotic ptosis, but it can also be done in congenital ptosis with good levator action and mild ptosis only. So these sutures are passed through the superior border of tarsus, and this is the Putterman's clamp where and you can see this is the conjunctiva. About 8 millimeter of conjunctiva has to be excised for correcting 2 millimeter of ptosis. So this is the Putterman's clamp which has been placed, and these sutures, this is a Prolene suture which is passed from the skin side, and it is passed in a form of a continuous suture, and the tarsus is not excised, it is this conjunctiva which has been excised. If you want to additionally increase the effect, you can also excise a bit of tarsus. एक मिनट आप छोड़ दीजिए ना, आप भी उधर से उसको कर्सर को पकड़ते हैं. Okay, now this is a ptosis sling, which is the commonest surgery which is done, which can be done by anybody. So this is a silicone sling which is used for severe ptosis, and these are the markings which are done, one in the center and then 3 millimeter from the lid margin. I like to use 3 markings, and these are the forehead markings which are done, and what is important is that the central incision has to have a very good well dissected pocket so that there is no extrusion of the silicone. So you start from the center and go towards the lid, and then these are the 3 passes that are made, and then you have to go the reverse way and bring it out from the medial end and then back to the central marking. So now this silicone can be either tied vertically in the sleeve, it can be passed vertically, or I like to put it horizontally, the 2 ends together, and you just tighten it and you get a very good result post-operatively on the table. And the next part is to bury this silicone, which is the most important part, because all the problems with silicone are either related to breakage, which can be avoided by using just the suture tank to hold it, or if it is not buried properly. So this has to be buried well below the orbicularis, and then the skin has to be closed. So these are the main. LPS resection is more or less similar. I'll just rush it fast. This is similar, just the LPS is disinserted from the tarsus. And now instead of frontalis, here you can see once the LPS is mobilized, depending on how much you want to do the resection. So if it is a small resection, it's usually 10 millimeter. If you want to go for larger, it would be about 14 millimeter. And this is the interior surface of tarsus where you pass the 5-0 vicryl suture and through the LPS muscle. And then the sutures are tied onto the LPS, and on table, if it is under local anesthesia, you can titrate on the table itself. If it is in general anesthesia, then of course you have to decide how much to resect. And then after the resection, the lid crease forming sutures from skin, orbicularis, LPS, and then back to skin, and the skin suturing has to be done. So just to summarize, because of shortage of time, I'm not showing any PPT. So if it is a small resection, you can go for small LPS, it is a mild ptosis, small LPS resections can be done, or you can go for Fastenella served or MMCR. If it is a moderate ptosis, depending on the LPS action, if it is a very good LPS action, then it is better just to go for, say, about 14 millimeter of resection. If its LPS section is, let's say, about fair, then you have to go for resections right till the Whitners. I never do supramaximal resections anymore. If the LPS action is poor, let's say about 4 millimeter, and it is the your ptosis is severe, and it is a congenital ptosis, then it would be better that you go in for sling procedures, or you can go for a frontalis advancement with the sling. I never do supramaximal resections anymore. Dr. Tanvi, you can come and just present. Sutures that you are passing for making the lid crease, I pass them a little closer to the lid margin, and then instead of giving, usually we give 3 sutures, I give at least 5 to 6 lid crease forming suture, and on table only your lashes should evert. If they are not everting, you are going to have a very bad time post-operatively.
Okay, my topic is on lid laceration and coloboma repair. I'll just go through it very briefly. So if a patient comes to us with, I'll skip the first few slides. If the patient first comes to us with a lid laceration, it's important that we don't directly jump to repairing the laceration. It's first is that we assess the systemic status of the patient, and second is the ophthalmic status. So in systemic status, we stabilize the patient. We take care of the ABCs of emergency care, the neurological status, and if cervical spine injuries are there, you accordingly ask for any imaging. Secondly, we look at the ophthalmic part of it. It's important, our first and foremost aim of rehabilitating a patient is preservation of vision rather than cosmesis. So the most important is we have to rule out globe ruptures and occult globe injuries. So once all of this has been ruled out, now we can focus on the lid laceration. So a brief history regarding the kind of trauma can give us some clues regarding the type of injury we can expect during surgery. So sharp traumas are usually associated with levator muscle or optic nerve injuries. Blunt traumas are associated with orbital fractures or canthal avulsions, and bite and claw injuries are very notoriously associated with canalicular lacerations. It's also important to examine the number of lacerations, the extent and depth, if the margin is involved, is the canaliculus involved. We'll look at each of these in the next few slides. So after all this, what is our goal of surgical repair? First and most important, preserve the eye and vision. Secondly, maintain the function. And third is restore the cosmesis. So all of this can be achieved by a well-executed primary repair. So some few principles of eyelid repair is, first, the repair should be done in layers, deep tissues first and superficial layers next. Secondly, identify the landmarks which help us to reapproximate. Like in this picture we can see these acute apices, angulations in brow hair. They serve as important landmarks for suturing the laceration. And if the orbital septum is damaged in the trauma, it's important that we don't repair that, because that can result in post-op retraction and lag ophthalmos. So in superficial lid laceration repair, it's as simple as it can get. So we basically suture it with 2 to 3 mm distance between the two sutures. The most important principle that we need to ensure in this is to avoid wound tension. So if by chance if the wound is not apposing well, it's important that we undermine the skin and allow good apposition of the laceration. Now, what about eyelid margin repair? Eyelid margin lacerations are characteristically repaired in the form of a vertical mattress suture. So this vertical mattress suture is in a characteristic far near fashion. So what is the meaning of that? We pass the first bite about 3 mm from the laceration margin to exit 3 mm on the other side. And the same part is reversed and exited at around 1.5 mm on either side. So, and the deeper parts of the laceration can be repaired with direct suturing. These direct sutures we have to ensure do not go full thickness through the lid, otherwise they can rub over the cornea. These vertical mattress sutures are passed at 3 points, A, B and C, which is the anterior lid margin, the grey line and the posterior lid margin. So it's important if a patient presents to us with a margin involving laceration, we debride the wound in the form of a pentagon as shown previously, because this is the outcome when we suture that. However, if we suture the margin in the form of a V, it results in the formation of a lower lid notch, and that is functionally as well as cosmetically undesirable. So some lacerations may appear to be quite small on the anterior lamella, but they have a very deep component on the posterior lamella. So it's very, very important that you evert the lid always. Now, what are complex lacerations? They are those which are associated with tissue loss. So whenever there's tissue loss, direct closure becomes difficult. So in such cases, to avoid any wound tension and eventual wound dehiscence, it's important that we relax the lid. Now, like in this patient now, there is a large upper lid defect, which is not amenable to direct closure. So in such a patient, there is a superior cantholysis done, which is cutting the crura of the lateral canthal tendon. This causes horizontal relaxation of the lid, which is now easily slid medially to close the defect. Larger defects can also be closed by Tenzel's flap. Now, what about canthal injuries? We know the medial and lateral canthal angles are acute, and this is important to prevent epiphora. So whenever the canthus is involved in any laceration, it's important that we repair that too. So before repairing the canthus, it's important that we intubate the canaliculus and stabilize the fractures. And the most important principle to follow in these canthal injuries is to maintain a superior and posterior pull to the lid. What about canalicular lacerations? They are very characteristically associated with dog bites. And it's important that we repair it within the first 48 to 72 hours, because as the time passes and the tissue edema increases, it becomes difficult to identify the cut ends of the canaliculus. Once the cut ends are identified, it's important that we place a stent. Like in this picture, we can see a stent has been passed through the puncta, through the proximal cut end of the canaliculus, through the distal cut end, and then till the hard stop is felt. And the rest of the lid is sutured by the principles that we've discussed in margin laceration repair. So this patient presented to us in an emergency with margin involving laceration. This is a close-up photo which shows that the canaliculus is involved. So the probe was passed intraoperatively, which shows the puncta and the proximal cut end. And this is the result at the end, showing a well-placed mini monoca stent and a sutured laceration. This is another patient which has a bicanalicular laceration, and this is the outcome on day 5, day 7, and day 10. A brief about coloboma repair. We won't go much into the depths of it because that involves a lot of reconstruction. Just remember that one, we have to do a complete physical examination in these patients to rule out syndromic associations like Fraser's and Golden Heart. And second, look at the amount of corneal exposure that occurs because of a coloboma. If it's too much and there is exposure keratopathy, it's important that we surgically intervene immediately. So this is one patient who had bilateral upper lid colobomas. So how did we repair this defect? In the left eye, we basically did a superior cantholysis and slit the lid medially. This resulted in closure of the coloboma in the left eye. However, in the right eye, the defect was quite large, and this was not enough. In addition to a cantholysis, we basically took a rotational tarsal graft from the lateral portion of the lid. And this was the outcome at the end of 1 month, where the lid appears to be formed on both sides. This is another patient who had acquired lower lid coloboma following excision for a malignancy, and this was repaired using a Hughes tarsoconjunctival flap. This is another patient who had an upper lid coloboma following excision of a malignancy, who was repaired using a Cutler beard, which is a full thickness flap that we take from the lower lid and suture to the upper lid. This is the outcome at the end of 6 weeks. So the take-home message is it's important that we do a thorough examination in the presence of a laceration, not just ocular but also systemic. Secondly, rule out any embedded foreign bodies, which also need to be taken care of. Third, avoid wound tension. And fourth and most important, our main aim is preservation of vision, followed by function, followed by cosmesis. Thank you.
Thank you so much, Tanvi. And I'm really grateful to all the audience who are still sitting and listening to us. And Shalu, any last comment on your part before I give it to Dr. Kasturi?
All the speakers have covered their topics very well. So basically in trauma we have to, as already stressed, that we have to evaluate the patient before we jump for any repair. And all the videos shown by Dr. Ruchi are well described. So audience should ask any question if they have any query. Yeah. This is the most distressing distichiasis basically. Thank you.